Hello, good day. This is Senior Clerk Hazel Aspera from the Liceo de Cagayan University College of Medicine, and I will be talking about acute angle closure glaucoma. So for starters, let's begin with the definition of glaucoma. So according to the Glaucoma Research Foundation, it is a complex disease in which damage to the optic nerve leads to progressive irreversible vision loss. So to be specific, acute angle closure glaucoma, according to the American Academy of Ophthalmology, it is a group of diseases in which there is reversible or adhesional closure of the anterior chamber angle. So this can help us quickly distinguish this from open angle glaucoma, in which there is no such closure of the anterior chamber angle. So the angle remains open and intraocular pressure rises despite of the open angle. So it may occur in an acute or chronic form. In the acute form, which is what we will be discussing today, the intraocular pressure rises rapidly as a result of a relatively sudden blockage of the trabecular meshwork by the iris via the papillary block mechanism. This is in opposition to the chronic form in which the blockage of the anterior chamber angle occurs much more slowly, and so the symptoms will not be as sudden, nor will they be as dramatic as in acute angle closure glaucoma. So just a review of the relevant anatomy and physiology. I'm sure we're all very familiar with the structure and the function of the eye, and this is a cross section, and what we will be focusing on today will be this part. So let's go to the next slide. This is the part where we can clearly see the production and removal of the aqueous humor. So what happens here is that aqueous humor is secreted by the ciliary processes. It enters into the posterior chamber and exits the posterior chamber via the pupil, and then it enters into the anterior chamber. It will circulate there, and the excess will pass through the trabecular meshwork, and it's finally drained into the scleral venous sinus or the canal of Schlemm, and into our circulation. And it is important for the aqueous humor to be there and to kind of flow, because first of all, it helps maintain the intraocular pressure. We can think of the eyeball as a fluid-filled balloon, and as with any balloon, it is easier to maintain its shape if it is filled with an adequate amount of fluid. So this is one of the functions of the aqueous humor. Second, it provides nutrition for the avascular tissues, because aqueous humor isn't just water, it also has protein and other nutrients that can help maintain these tissues. So this would include the lens and parts of the cornea. And it also provides some refractive power. So as for refractive power, just a short review, the part of the eye that provides the most refractive power is the cornea, and followed by the lens, and the aqueous humor provides a minimum amount of refractive power. So there are three factors that can affect the intraocular pressure, the first of which is the rate of production of aqueous humor by the ciliary body. And second is resistance to aqueous outflow through the trabecular meshwork and Schlemm's canal. So this is actually the mechanism by which that becomes a problem in acute angle closure glaucoma. And third is the episcleral venous pressure, which would prevent drainage of our aqueous humor into the sinuses. So as for our pathophysiology, risk factors, first of all, is hyperopia or farsightedness. So we can, if I can draw a normal eyeball here, and then our lens and our iris, and have an eyeball that is hyperopic. So eyeballs that are hyperopic tend to be shorter. So lens and iris. So as you can see, the angle of the anterior chamber tends to be wider in a hyperopic, in a normal eyeball as compared to that in a hyperopic eyeball. And that's one of the reasons why there is greater potential for blockage in this kind of eye. It is also more common in women than in men. We aren't exactly sure why this is so, but some think it may be because women have smaller eyeballs than men, although this isn't like 100% proven why this is the exact mechanism for this. Another is cataracts, which can also cause thickening of the lens. An ectopic lens, the displacement of a lens which can cause blockage of the flow of aqueous humor. And next is age. This is due to age-related changes in the eyeball, which we know as presbyopia. Only that in presbyopia, we are more familiar that it is the inability of the lens to accommodate. So that's one factor. But another thing that happens with age is that the lens also kind of thickens. And so this can increase the risk for a blockage. Next is family history. So if you have someone in the family directly related to you who has acute angle closure glaucoma, you have a higher risk than the general population of also developing it. Next is neovascularization of the angle and tumors, which can both cause physical blockage of the angle, and it can also be drug-induced. So let us go to our pathophysiology. So given the above risk factors, what happens is that the pupillary margin of the iris becomes opposed to the anterior surface of the lens. So it can happen like this. So this is our lens and this is our iris. So what happens actually is that the iris, let's change color. The iris becomes opposed to the lens, and it's important to note that this is greater when the pupil is mid-dilated. So that's an important point which we will go back to later. And then because of that, our aqueous humor begins to build up here, because as you can imagine, our ciliary body still continues to produce aqueous humor, and so it's not able to exit the posterior chamber, so it just builds up over there, and this can cause elevated pressure in the posterior chamber. And because of elevated pressure, so the aqueous humor just continues to push up against the iris, what will happen is that the iris will bow forward due to the pressure. And then, because it also opposes to the trabecular meshwork as this happens. So what happens is that the aqueous humor is now able to flow into the anterior chamber, but because of this opposition, it's unable to exit. So we can actually see this as a narrow angle on gonioscopy. So here is an image of just a diagram of the stages of the angulation of the anterior chamber angle when it becomes blocked. And because of this, the aqueous humor is unable to drain out of the anterior chamber. So this is appositional in nature. Another mechanism would be synechial closure due to adhesions between the trabecular meshwork, and that's a whole other pathophysiology. Although this also, whether it's synechial or it is due to apposition, it causes the buildup of aqueous humor, causing increased intraocular pressure. So the buildup of aqueous humor here increases our intraocular pressure. And this we can observe as an intraocular pressure of more than 20 millimeters mercury on tonometry, or when we palpate the eyeball, it will be rock hard. So what happens when intraocular pressure increases? Well, first of all, there is decreased nutrition to the lens epithelium. This is because the aqueous humor is unable to circulate due to the blockage. It's unable to replenish itself, and so the lens epithelium will have less nutrients delivered to it, and less nutrients means less energy. Less energy is basically less ATP, and this can cause necrosis of the lens epithelium. And we can actually see this as Glaucomflecken, or whitish opacities on the anterior lens capsule. So we can see that in this image. So these whitish opacities are one of the signs of our lens epithelium necrosis. So another thing that happens is that the pressure will compress the surrounding structures. So one of the effects is the stimulation of pain receptors, particularly in the cornea, which is full of nerve endings. And this can lead to one of the cardinal manifestations of acute angle closure glaucoma, which is eye pain, which may be accompanied by headache, nausea, and vomiting. There will also be circumcorneal congestion, so congestion of the blood vessels around the cornea, which can lead to a red eye. So our patient will have eye pain and present with a red eye, as illustrated. And there will also be corneal edema. This is because of pressure to the cornea, which causes inflammation, but it's also partially because the avascular part of the cornea will no longer be supplied by the aqueous humor of nutrients, and so these two factors can contribute to corneal edema, which will lead to a cloudy cornea and physical exam, which you can actually also see here. And it will also result in visual disturbances, as our cornea is one of the major refractive medium of the eye, and an edema, cloudiness or opacity of the cornea, can actually scatter light, and this can result in blurring of the vision. So this intraocular pressure increase can also cause damage to the optic nerve. So theoretically, what happens is that increase in the pressure in the anterior chamber causes the lens to push against the posterior chamber, which also increases pressure there. And so this increasing pressure can damage your optic nerve, and this also results in the visual disturbances and an enlargement of the optic cup on fundoscopic exam. So we can see this here. So here to the left is a normal optic disc, and this is the optic cup. So our normal cup to disc ratio is 0.3, which basically means that this optic cup is about 30% of the area of our optic disc. Compare this to cupping in glaucoma. So here is the optic disc, and this is the optic cup. Note that this ratio is it's far more than 30% of the area of our optic disc, and that is what we call glaucomatous cupping. And next, the iris sphincter becomes ischemic when pressure is more than 40 millimeters mercury. So let's remove this. So our iris is supplied by marginal arcades of blood vessels, and since these blood vessels are also located at least partially in the anterior chamber, increased pressure will compress these vessels, and thus there will be limited blood supply. So again, limited blood supply means limited nutrients, limited energy, limited ATP. So the iris will be unable to do its function. So this can result in a fixed or sluggish mid-dilated pupil. So we can see the symptoms we have mentioned earlier. So we have our mid-dilated pupil here, a corneal haze, and a red eye. So this is relevant because the apposition of the pupillary margin of the iris to the lens is greater when the pupil is mid-dilated. And this is one of the reasons in which that acute angle glaucoma is one of the conditions that requires treatment within hours, because this cycle of apposition and then buildup of pressure can be vicious, and it can go on and on until we get permanent damage of the ocular nerve, and apparently we don't want that. So I hope this pathophysiology has allowed us to understand overall the process of what exactly happens in our eye, and also understand signs and symptoms and the test results that we get when we assess a patient with acute angle closure glaucoma. So for our diagnostic approach, of course, most important in any condition is history and physical examination. And this will include diagnostic tests such as tonometry, as mentioned earlier, to measure the pressure, intraocular pressure, gonioscopy, and slit lamp examination to more closely examine the structures of the eye. We get to see the pathognomonic or some of the distinguishing characteristics of this condition, and gonioscopy specifically to actually view the angle. So aside from this, no other labs or imaging are usually necessary, because these are enough to diagnose acute angle closure glaucoma. So diagnostic criteria for acute angle closure attacks include the presence of at least 2 of the following symptoms. So ocular or periocular pain, nausea and vomiting, an antecedent history of intermittent blurring of vision with halos, so these would be previous attacks basically, and a presenting intraocular pressure of more than 21 millimeters mercury. And also the presence of at least 3 of the following signs: conjunctival injection or eye redness, as mentioned earlier, corneal epithelial edema, a mid-dilated unreactive pupil, and a shallow anterior chamber. So how is it treated? So when a patient comes in and you suspect or you diagnose acute angle closure glaucoma, it is important to give immediate initial treatment in order to prevent further damage to the optic nerve. So this will include, these are basically mechanisms that can help reduce intraocular pressure. So first, we can suppress aqueous humor production by giving carbonic anhydrase inhibitors, which is one of the enzymes that the ciliary body uses to produce aqueous humor. Or we can give beta blockers or alpha-2 adrenergic agonists, which decrease the production of aqueous humor. And we can also decrease pupil block through cholinergic agents. However, these must be given with care, because they are contraindicated in lens-induced and malignant glaucoma, because in these cases, cholinergic agents can cause, what do you call this? Paradoxical closure of the anterior chamber angle. So next, we can also attempt to decrease fluid in the anterior capsule with hyperosmotic agents. So hyperosmotic agents in the blood, in our circulation, can actually pull the water within the anterior chamber or the anterior capsule back into the bloodstream, and so this can help reduce the pressure. However, these measures are only temporary. If we do not give definitive management, there is always a risk that future attacks of acute angle closure will occur even if they are relieved the first time. And also, in addition, there is also a risk that the the other eye will also experience acute angle closure attacks because of apparently similar anatomy between the two. So definitive management is usually surgery. We have laser peripheral iridotomy, which is basically punching a hole or making a hole in the iris at the periphery so that the pupil becomes not the only exit point of aqueous humor from the posterior to the anterior chamber. So if the aforementioned apposition happens, the aqueous humor is still able to exit through the periphery. And then there is also laser iridoplasty or gonioplasty, which is basically fixing the angle between the iris and the pupil so that it becomes wider, or the iris and the trabecular meshwork so that this becomes wider. And also, if applicable, if this is the cause, we can also do lens extraction surgery for ectopic lens, or if the lens is really a major factor in angle closure. And that is all. Thank you so much for your attention. I hope you all learned something from this report, because I really learned a lot in making it. And these are the references that I used, and these are the images that I used. Again, thank you very much.